Good morning, respected teachers and my dear friends. Today, I'm from a Department of Clinical Hematology and Medical Oncology, and we are presenting a case which has been under our follow-up for the last 1.5 years. So this is a case, a 27-year-old female patient presented in March 2021 with complaints of heaviness of the left upper abdomen and early satiety for 3 months duration, loss of appetite, dyspnea on exertion for 3 to 4 months, MMRC grade 2, with weight loss of approximately 5 kgs over the previous 3 months. There was no history of any fever, bleeding manifestations, jaundice, urinary complaints, chest pain, palpitations, orthopnea, pedal edema, visual disturbance, or alteration in sensorium. There was no history of any chronic drug intake, prior surgical procedures, prior blood transfusions, no significant past or family history. On clinical examination, patient had pallor, there was no icterus, cyanosis, clubbing, edema, lymphadenopathy. Systemic examination revealed a spleen which was measurable 8 cm below the left costal margin. Rest of the systemic examination was non-remarkable. Initial investigations with which the patient had come to us was showed hemoglobin of 7.51, a TLC of 2,41,000, platelets were normal 3,30,000, KFT LFT was within normal limits. We repeated these investigations in our lab, and that showed in March 2021 hemoglobin of 8.3, TLC of 2,78,000, platelets of 4,14,000. Differential showed neutrophils of 39%, lymphocytes 2%, eosinophils 2%, basophils were increased, basophils were 7%, monocytes 2%, and there was a left shift, promyelocytes 2%, myelocytes 28%, metamyelocytes 12%, and blasts were present in the which were 6%. The peripheral smear revealed RBCs were normocytic normochromic with few nucleated RBCs. WBCs, there was leukocytosis with left shift and basophilia with 6% blasts. These blasts are basically large atypical cells with high nucleocytoplasmic ratio, and they had prominent nucleoli. Platelets were found to be adequate on smear. Yes. So these are the blasts, these are the large blasts, and they have prominent nucleoli. So the workup here, the patient had leukocytosis with splenomegaly. The peripheral smear was suspicious of a chronic myeloproliferative neoplasm. So patient was planned for bone marrow aspiration, trephine biopsy, cytogenetic and molecular study. So a bone marrow aspiration was done here, which showed bone marrow was particulate, though it showed imprint smears were moderately cellular. ME ratio was increased to 21:1. Myeloid hyperplasia was present with full range of maturation. Erythropoiesis was suppressed, and there were some megakaryocytes which were of dwarf forms, and 7% blasts were present. So this bone marrow was consistent with the diagnosis of chronic myeloid leukemia, chronic phase. We further evaluated. A karyotyping and molecular study was done. Cytogenetic showed a 46X translocation 922 with no additional cytogenic abnormality. The importance of additional cytogenic abnormality is that their presence indicates a more advanced disease. So this is the typical karyogram of a CML patient, where there is a translocation between the chromosome 9 and chromosome 22. So a part of the chromosome 9 is a part of the chromosome 22 is broken down and it gets attached to chromosome 9. So we have a shortened chromosome 22, one arm, which is known as Philadelphia chromosome. And BCR ABL was also done, which showed 47.07% BCR ABL on IS scale. So a diagnosis of chronic myeloid leukemia in chronic phase was made. A risk stratification was also done at the baseline following the European leukemia net criteria, which showed low risk disease with low chances of progression to advanced phase and low disease related mortality. So CML is basically a myeloproliferative neoplasm resulting in an uncontrolled proliferation of myeloid lineage. It accounts for about 15 to 20% of the adult leukemias, and the hallmark finding is reciprocal translocation between chromosome 9 and 22, with the shortened chromosome 22 designated as Philadelphia chromosome. This results in fusion of two genes BCR on chromosome 21 and ABL1 on chromosome 9, resulting in the BCR ABL1 fusion protein with unregulated tyrosine kinase activity. So after the diagnosis was established, patient was started on treatment. The initial management for cases of chronic phase CML is tyrosine kinase inhibitors. So patient was started on oral imatinib therapy at 400 mg per day dose, which was tolerated well. There were no immediate or early adverse events. Patient had progression, had disease control as per expected line of as per expectation. Patient achieved complete hematological response with regression of splenomegaly by 3 months of imatinib treatment. So even after achieving CHR, patient had continued to be in our follow-up for the next 15 months. So this has been the patient's hematological parameters over the next 15 months. There was mild anemia which was attributed to iron deficiency, and patient was provided with iron supplementation. The important thing is TLC to meet WHO criteria of hematological remission, TLC has to be less than 10,000. So the patient has consistently had a TLC less than 10,000 over the last almost 15 months, for which we have the data, and platelets were also within normal limits during this period. So by this time patient had achieved hematological remission. We also monitored patient based on BCR-ABL transcript level as per the ELN criteria. So at the baseline we had a BCR-ABL of 47.07%, which over 3 months of treatment reached to 0.154%. So a BCR-ABL reduction to less than 10% is considered as a significant response, known as the early molecular response. By 6 months, it had come to 0.083%. Now, anything below 0.1% is considered as a major molecular response, and by 12 months, it had come down to 0.004%, which as per the guidelines, this is considered as a deep molecular response. So patient had progressed well with achieving all the milestones before the expected time duration. So patient had achieved complete hematological response within 3 months. Early molecular response was also achieved within 3 months, and major molecular response, which in most cases takes more than a year, was achieved within 6 months in this case. So patient followed up with us. Patient was continued on imatinib 400 mg per day, and she was compliant to treatment. And after achieving CHR, she was on 3 monthly follow-up in OPD as per ELN and NCCN recommendations. Her last hematology OPD follow-up was in June 2022, at which time she was in complete hematological remission. So coming to the long-term survival and data for these patients. The median survival in chronic phase patients is estimated at 25 to 30 years, and progression to advanced phase CML or blast phase has been reduced to 1 to 1.5% per year, compared with more than 20% per year in the pre-imatinib era. And achieving a major molecular response, which our patient had achieved by 6 months, predicts a CML specific survival close to 100%, as disease progression is uncommon once this level of cytoreduction has been achieved. So, and the other important milestone that our patient reached was deep molecular response, defined as BCR-ABL values of less than 0.01%. So it is also seen that MR4, if it's maintained for at least 1 year, represents a secure response threshold for patients with CML, after which no MR3 loss like increase in BCR-ABL transcript by 1 log, does not occur if certain conditions are satisfied, which include a standard TKI dose, full compliance, and lack of previous TKI resistance. Our patient had achieved MR4 and was compliant to a standard TKI treatment. But however, this patient presented again to us in the month of September, in the second week of September. She presented to our emergency department with complaints of acute onset of gum bleeding and spontaneous bruisage over abdomen and lower limbs of 1 week duration. There was no fever, no other bleeding manifestations. She was conscious, oriented, afebrile, and hemodynamically stable. There was pallor present. She had ecchymotic spots over abdomen and bilateral legs, but there were no organomegaly or lymphadenopathy. The investigations this time showed a hemoglobin of 9 gram, TLC of 59,000 and platelets of 11,000. Coagulation parameters were within normal limits. Dr. Subhajeet will show the findings this time when the patient presented to us for emergency.
So on 13 September, we did a peripheral blood smear which revealed predominantly normocytic normochromic RBCs with reduced RBC density, and in between these atypical mononuclear cells were there, and there was leukocytosis. So you can see these cells which are larger than the RBCs, almost 2 to 3 times of the size of the RBC, as well as they have very high NC ratio. Unlike the myeloblast that we have seen before, they doesn't contain any nucleoli and very scanty amount of cytoplasm. So it looks like in lower power that they almost has no cytoplasm. So these are morphologically resembling lymphoblasts. So then we went for a marrow, and marrow was kind of diluted. Aspirate smears were particulate, and however imprint smear were moderately cellular and had the same kind of blast in the marrow. As I described before, that these blasts are 2 times the size of small lymphocyte nucleus, had high NC ratio, round to slightly irregular nuclear contour, and coarse to fine chromatin, and inconspicuous to very small nucleoli, and scant cytoplasm. So we gave a provisional diagnosis of CML blast crisis, as it was a known case of CML, and a flow cytometry was done which revealed these blasts were TDT and 34 positive. That means these are immature cells, not mature lymphocyte. They also expressed B cell marker like CD19, 10 and CD20, and they were also positive for 38, and there was deemed positive for CD33 in a subset of blasts. So these are this is a myeloid associated marker CD33, which is commonly seen in CML blast crisis or CML lymphoid blast crisis, and sometimes pH like or BCR-ABL like ALL. You can also see, or pH like ALL, aberrancy of myeloid antigen is very common and suggestive of. So on the based on flow cytometry, suggest a diagnosis of B lymphoid blast crisis was given. Then I think we continue, sir. BCR-ABL.
We had also repeated a BCR-ABL at this point of time. So the BCR-ABL level had also risen from 0.004 to 62% over a period of 3 months. And so a diagnosis of CML blast phase was made based on the diagnostic criteria of at least 20% blast in the blood or bone marrow, or presence of an extramedullary accumulation of blast. These are the 2 criteria to say that patient has progressed to CML blast phase. A blast phase transformation can be in the form of a lymphoid blast transformation or myeloid blast transformation, or in some cases a mixed phenotype may be present. In our case, the patient had progressed to a lymphoid blast phase. So patient was started on induction chemotherapy, ALL BFM 2009 chemotherapy protocol, along with the 2nd generation TKI dasatinib for lymphoid blast phase of CML. So after we had started treatment, we also considered why did imatinib fail here after such after achieving all the major responses that we expect in a patient, and when such responses are associated with a good long-term outlook. So the important causes for TKI resistance are, some are BCR-ABL1 independent and some are dependent on that. So the most important common thing we see is patient-related poor compliance, which was ruled out here. Patient had been taking imatinib regularly. Pharmacological poor intestinal absorption, drug interactions. Patient had not been on any other medication. And leukemia cell related sometimes may be seen, but these are rare events where there is increased level of exporter or reduced level of the drug transporter. Sometimes there is clonal evolution, and sometimes alternate pathways become overexpressed. The more common mechanism which can be detected by a lab laboratory investigation is BCR-ABL1 dependent mechanism. So this may be in the form of increased expression of BCR-ABL1 gene because of gene amplification or mutation in the ABL kinase domain. So in our case, we found a tyrosine kinase mutation, domain mutation by PCR. We found a T311I mutation where threonine has been substituted by isoleucine. So we looked at the most common BCR-ABL kinase domain mutations. These are the commonly reported mutations, and we did not see the mutation that we have found in the list of these mutations. Then we went back and checked for the other reported mutations, and even in this large number of mutations, we did not find this mutation. So this is probably a novel mutation. There is absence of published literature in English language on this specific mutation and its sensitivity to other tyrosine kinase inhibitors. So we do not know how well dasatinib or any other second generation tyrosine kinase inhibitor will act on this. So our final diagnosis was B lymphoid blast phase of chronic myeloid leukemia with a disease progression from CML chronic phase with T311I mutation in BCR-ABL kinase domain. So further course was patient is currently on induction chemotherapy. She has completed second week of induction chemotherapy at present and is tolerating chemotherapy well. Further management plan will be completion of an induction therapy followed by consolidation chemotherapy and allogenic hematopoietic stem cell transplantation. Achievement of a complete remission prior to HSCT will be an important milestone for this patient. This patient ideally needs to go for an allogenic transplantation, and the long-term data even for these patients who have progressed to blast crisis, allogenic transplantation helps. Even in this unselected data where the transplantation protocols were different, conditioning regimens were different, and even the donor types were different. Some were matched donors, some were matched sibling donors, some were matched unrelated donors, and some were haploidentical transplantation. Even here, the overall survival can be expected to be around, for 50% of the patients, overall survival is in the range of 10%. Achieving a remission status prior to transplantation is important because the patients who were transplanted in the blast phase have poorer outcome compared to patients who achieved a second remission and were transplanted. So in this case, we have come across a novel mutation in TKI domain, and the patient is currently on chemotherapy, and we expect to achieve a complete remission status and then proceed for allogenic stem cell transplantation for optimal outcome, for the best outcome for this patient.